All right, so we're going to go ahead and begin. Speaker this morning is Dr. Chris Moertel. Chris is a professor of pediatrics in the Division of Pediatric Hematology Oncology. I have known Chris since 1984. So Dr. Moertel was an incoming intern when I was a departing senior resident at Texas Children's Hospital. I don't remember too much other than I think I met you on the 7th floor on 7th South.
Marty Lawrence said you should get to know this guy because he's going to Minnesota.
Okay, so anyway, Chris came back to Minnesota after his residency and then fellowship at the Mayo Clinic, and when he got back up here, worked in pediatric oncology at Children's in St. Paul for a long time. We were fortunate to recruit Chris to lead the neuro-oncology program here 15 years ago or something like that. It's been a little while.
Making me older.
Yeah. The thing that Chris did when he got over here that I think is important lesson is Chris spent his first couple of months essentially going from lab to lab and from person to person around the medical school, looking for collaborations, looking for new connections that could be made to essentially move a program along. And he did that incredibly well. I think what he's going to talk to us about today in neurofibromatosis is an example of a lot of those connections that he's developed. So, Chris, thank you. Glad you're here.
Thanks, Joe. What I actually did was run around and find everybody who was smarter than me, which took me like a day. And hanging out with smart people makes you smarter. And so people think that I know what I'm talking about, which you'll soon learn I don't. But I'm grateful for the people around me here, and so we'll roll. We're going to put on our seat belts because I've got a lot to talk about in a short time. One of the inspirations for this was there was a review of in-service scores and board scores from a couple years ago that Emily Borman-Shope sent out, and oops, neurofibromatosis is a knowledge gap for the house staff here. So hopefully those who are here can share it with the house staff who aren't. My disclosures, I'm a consultant for recombinetics. I'll refer to them later in the talk, and I'm also going to talk about off-label use of one specific medication today, trametinib. So I've got 3 questions, and we'll get these settled and move on. Neurofibromatosis type 1 is most frequently limited to cutaneous manifestations alone. True, false, that's easy. You have a 50% chance of getting that right. Because NF1 is a genetic disorder, there are really no therapeutic interventions that make a significant difference in outcome. True, false. And finally, NF1 is most closely linked to which of the following syndromes? NF2, Fanconi, McCune-Albright, or Noonan syndrome? Let's just get straight to it and answer the first question. NF1 is one of the RASopathies. And the RASopathies are so named because of, excuse me, turn this around, because of mutations that arise that allow the phosphorylation and activation of the oncogene RAS. That then sets up downstream activation. And these RASopathies, of which neurofibromatosis is the most common and most prominent, include neurofibromatosis Noonan syndrome, which is essentially a variation, mutation of neurofibromatosis, Costello syndrome, Legius syndrome, cardiofacial cutaneous syndrome, Noonan syndrome, and Leopard syndrome, now known as multiple lentiginous syndrome. If you understand the chemistry of these RASopathies and specifically understand the chemistry of neurofibromatosis type 1, it allows you to intervene in the syndrome. And we've done major work here at the University of Minnesota, specifically in David Largaspata's lab, that's allowed us to really participate internationally in the further description of the syndrome. Specifically focusing on RAS activation that results from a mutation in the protein neurofibromin. Neurofibromin in its natural state, its wild type state, does not allow RAS activation. And so it keeps RAS from activating and turning on these downstream other proteins. However, if neurofibromin is mutated, all of this goes downstream, and there's two specific pathways, the one I mentioned before, and over here is the PI3 kinase AKT mTOR pathway, and mTOR is familiar to some of you in the audience. We'll talk about that later. So neurofibromatosis type 1 is the most common single gene disorder affecting the human nervous system. The NF1 gene encodes for a protein called neurofibromin, as I said. It has many organ manifestations far beyond the skin, and manifestations develop through life, requiring longitudinal evaluation. A number of years ago, a group got together and described the natural history of the condition, and you'll see that there are things that develop right at birth that we can observe: cafe au lait macules, plexiform neurofibromas, and clinically detected then when kids start to toddle, tibial dysplasias appear, skin fold freckling shows up around age 2 to 3, and all of these other things, dermal neurofibromas, Lisch nodules, plexiform neurofibromas, appear later. Optic gliomas probably are present at birth, but escape detection until around ages 3 to 5. Number one, neurofibromatosis is a skin disease. And this leads us to the first NIH criterion for diagnosis of neurofibromatosis. That is the presence of 6 or more cafe au lait macules. Now, if you're prepubertal, they only need to be 5 millimeters. But once you've gone beyond at 2 or beyond puberty, they have to be 15 millimeters in greatest dimension. I want you to notice, too, that by and large, most of these macules have a very smooth border, the coast of California, from which Dr. Neglia emanates. Axillary freckling, or as I call it, freckling where the sun don't shine, is an important part of this condition. The freckles seem to first appear in the axillae in young children, and then they'll appear in the inguinal region, and with maturity in the submammary region in females. Dermal neurofibromas are the scourge of this disease, causing a lot of cosmetic issues and a lot of quality of life issues for many patients as time goes by. This is a close-up, and in most of my adult patients, and my oldest patient, by the way, is 75, most of my adult patients, when I do the physical exam and describe dermal neurofibromas, I just say too many to count, because that's truly what it is, and you just try to focus on those that are causing specific issues. Other cutaneous manifestations. This is a xanthogranuloma. These tend to appear early in life and disappear spontaneously. Xanthogranulomas used to be linked with JMML, so early in my career, I got a lot of referrals for kids with NF who had xanthogranulomas and do they have leukemia? And indeed, the great majority don't. It just so happens that JMML is very rare in a common disorder. Hypopigmented macules can happen, and hemangiomas and other cutaneous angiomas tend to progress through life. The little cherry angiomas that you think of are actually very common in adults with NF. And then so-called vascular stains. Sheila McGinnis was one of the first to describe this when she was at Boston. Vascular stains like this are very common in NF and very frequently associate themselves with large cafe au lait macules. But cafe au lait macules do not make neurofibromatosis, and there are a group of disorders that can be easily confused with NF and should always be considered. This is a young man who came to me with a brain tumor and multiple cafe au lait macules and a diagnosis of NF1 that was made across the pond. And we see a cafe au lait macule here. He actually had 10 of them. He had a little axillary freckling. I don't know if it stands out well on the slide. And he presented with a glioblastoma. And it actually turns out he had a DNA mismatch repair syndrome called MSH6. It's very common in the Middle East and Pakistan, And so that should always be considered when we have patients show up that might emanate from that area of the world and have associated malignancies. Colon cancer and brain tumors are the two biggies, and brain tumors are the biggest in kids. And then there's the cafe au lait spot that is the coast of Maine, the jagged, raggedy coast of Maine, Acadia National Park. Think of it and you'll always get it right. This is McCune-Albright syndrome and not NF. This is another child that came to me with multiple cafe au lait macules, but oops, you look at the knees and shins and you see this. This is piebaldism, and it's a mutation of KIT, not RAS. And these kids don't develop malignancy or anything, but they do have this characteristic hypopigmentation on the legs, and of course white forelock, hence piebaldism. And Fanconi anemia, which is very common here because we have a couple of the world's leading experts, so we have a number of patients swimming around the medical center with cafe au lait macules associated with their Fanconi anemia. And the laundry list goes on, and Dr. Pierpont's in the audience, and she can tell you about every one of these, but suffice it to say that with this and what I showed you previously, cafe au lait macules do not make neurofibromatosis. Just one quick mention of Legius syndrome, otherwise known as spread 1. It has all the characteristics of NF1 except they never develop neurofibromas, they never develop optic gliomas, they never develop Lisch nodules, which we'll talk about in a minute, and there's no osseous dysplasia. And it's so common and so commonly confused that now we have a reflex test when we send off gene testing. If it's not NF1, they automatically analyze for the spread 1 mutation. NF type 1 is a disease of the nervous system, and I'll say nervous system structures. This is one of the very common features of NF and NF alone. These are UBOs, otherwise known as focal areas of signal intensity. And these areas are most common in the basal ganglia, but can also appear in the brainstem and cerebellum. For people not schooled about NF, these kids will be assigned a diagnosis of brain tumor, and that can lead to some very confusing circumstances for a number of my patients. Most patients these days don't have screening MRIs, so we don't see them in everybody, but everyone who has an MRI sometime between the ages of 3 and 15 will have UBOs. They tend to appear as time goes by up to age 2 or 3, and then they're all gone by age 25. They've never been able to associate these with anything. They're not associated with learning disorder, seizure, anything like that. They're just there. And then the biggest problem that people with NF have is with neurofibromas and plexiform neurofibromas. And these can be quite problematic into the teenage and young adult years. You start to develop these larger paraspinal neurofibromas, and indeed they can progress to the point where this is I don't know if you can see it, there's a tiny thin hourglass between these two neurofibromas that is the spinal cord. And I see patients walking into my clinic sometimes, I'm wondering how they walk, just because you see features like this. And I've learned over time not to get too crazy about them, because sometimes doing surgery on these leads to more difficulty than living with this compression. The disfigurement from these plexiform neurofibromas can be significant. This is a patient who has lower extremity involvement. Here, shoulder and neck involvement. We have a number of patients with significant facial involvement. So it's not only an anatomic issue for many patients, but a lifelong cosmetic issue. This is a young man in our clinic right now who's had this facial plexiform neurofibroma at an early age, and you can imagine the difficulties that causes in school. This is a young lady who has a plexiform neurofibroma involving her tongue that's impeded speech and swallowing. And this is another one of our patients who has a large cafe au lait macule in her upper chest and neck, and that belies the fact that there's a large plexiform neurofibroma under it. And this is something we've been monitoring closely and are pursuing therapy for because it's been beginning to cause her some issues. Plexiform neurofibromas are really interesting tumors because they're not one cell line. They actually start with Schwann cells as a result of RAS upregulation. And these Schwann cells are angiogenic, invasive, and secrete KIT ligand. And as a result of that KIT ligand secretion, they then recruit Schwann cells more. Abnormal growth properties in RAS signaling of mast cells are noted. And then finally, fibroblasts are recruited. Paraneurial-like cells are seen. And these are, because of the angiogenic properties of these tumors, they're highly vascular, and it's a huge problem to resect these, not only because they tend to intertwine between structures, but because once you get into them, they bleed like crazy. And this is an example of a patient who has had several surgical misadventures. I've seen many patients like this who have large plexiform neurofibromas that have attracted surgeons over time, and they just end up back to where they were. And you can see that this is quite problematic for him. Unfortunately, right now, surgical resection is the only standard treatment, but for many patients, surgical therapy really isn't a good option. The growth rate of plexiform neurofibromas is interesting depending on when they appear. If they appear early in life, there we go. Under 3, they display an incredibly fast growth velocity, and then as time goes by, their growth velocity slows. So detecting a neurofibroma in somebody in adulthood is quite different from finding one in a 3-year-old. And finding a plexiform neurofibroma in a very young child really commands very frequent monitoring and engagement of collaborative services. Subcutaneous neurofibromas happen too and develop over time. This is a subset of patients that is very difficult and maybe more predisposed to malignancy than others. But we have many patients who are just an ocean of subcutaneous neurofibromas. NF is an eye syndrome, and the most common, and here's the 4th diagnostic criterion, optic glioma. And there you can see a fusiform enlargement of the intraorbital portion of the optic nerve, and on this side it's relatively spared. Optic gliomas can be bilateral, unilateral, pre-chiasmatic, post-chiasmatic, chiasmatic. I'm grateful that we have a really outstanding crew of pediatric ophthalmologists here who help us out with these. Here's somebody with a chiasmatic optic glioma, and you can see its proximity to the pituitary gland and hypothalamus. And indeed, kids with these tumors are at very high risk for precocious puberty and a whole array of other hypothalamic pituitary abnormalities. Lish nodules. I'm very grateful to live in Minnesota because we have a bunch of pale-eyed patients, so it's easy for me to see them. If somebody's got brown eyes or early in life, a slit lamp examination shows these very, very well. They're unique to neurofibromatosis, and again, this is one of the diagnostic criteria. If more than 2 Lish nodules are present, you've got NF1. They don't tend to appear to the eye of the examiner until about 8 to 10 years of age. They are visible by slit lamp earlier, and of course, if your patient has brown eyes, they're pretty darn hard to see. NF1 is a skeletal syndrome. Diagnostic criterion number 6, the presence of osseous lesions, distinctive osseous lesions to NF, sphenoid dysplasia, thinning of the long bone cortex with or without pseudoarthrosis is seen, and this is somebody with tibial dysplasia, bowing of the tibia early in life, and the cortex underneath is very thin and prone to fracture, hence pseudoarthrosis. And this is sphenoid dysplasia, where the sphenoid bone simply isn't made. That's sometimes associated with a neurofibroma in the area, sometimes not. But it can lead to, again, disfigurement. This is one of our patients, and these are not the lower extremities, these are the upper extremities. Just a reminder that tibial dysplasia isn't the only dysplasia. Indeed, you can have dysplasia of the long bones of the forearm, and again, develop pseudoarthrosis there. So this was an early referral to our orthopedic colleagues. And then finally, and most importantly, is scoliosis in this group. This is not uncommon, but when it happens, and it happens to be dystrophic scoliosis, it can lead to significant quality of life issues that are lifelong. This is a young child who has a dystrophic spine, and you can see rotation of the spine. There's a disorder of the ribs associated with this called rib penciling. This is a gentleman who was in his late 20s who came to us, and his scoliosis film is pretty normal looking. He was actually in the Marines and was deployed, finished his Marine career, and came to us when he started to have neck pain because he knew he had neurofibromatosis. And in investigating his neck pain, we actually discovered this scoliosis, and you can see that his vertebra, his cervical vertebra here, is wedged, which is another common feature of scoliosis, dystrophic scoliosis in NF1. And the last characteristic of NF1 scoliosis is dural ectasia. The dura becomes ectatic and erodes vertebral bodies, and this can lead to a great deal of pain and disability. If we add up all of these, the Department of Defense gave David Polly and I a grant to score and characterize dystrophic scoliosis in NF1. And there are three characteristics we see on X-ray that we have confidence will diagnose dystrophic scoliosis and lead to appropriate management. Rib penciling that I noted, vertebral rotation, vertebral wedging, and then finally a location that's atypical for idiopathic scoliosis. In addition, we looked at snips that were previously associated with idiopathic adolescent scoliosis and found that indeed there's a correlation between those snips and the presentation of dystrophic scoliosis in NF1. This is an example of an adult patient who had scoliosis surgery early in life. And if I told you the name of the surgeon, a lot of people would go, oh yeah, I know him. But she appeared to us, here's her rod that was put in, here at Fairview actually, way back when. But she presented to me at age 35 to 40 with shortness of breath. And we did a chest x-ray, and here's her shortness of breath. And actually what it is a giant pseudomeningocele. She eroded through her vertebral bodies. Her dural ectasia became so severe and developed this large meningocele that involved the thoracic cavity. This was managed by Dr. Matt Hunt here, and actually today now her lungs are back to normal. He did a lot of different stuff to kind of help to decompress and patch this. But this is just a reminder, we see this over and over again when people with NF are instrumented early in life. Their bones don't heal. If you've got a dystrophic spine, it's made of dystrophic bone. And once you start to put in screws and wires, it's just a perfect place for things to erode through. So once you fix scoliosis, it's not fixed. You're in for a lifetime of monitoring, and this is a great case in point. This is a bit of trivia for all you pediatricians out there. The first pediatric subspecialty, orthopedics. Orthopedics, a straight child, get the kid to grow up normally, and this is their emblem, their orthopedic emblem, straightening out a dystrophic spine. NF1 is a cardiovascular syndrome. One of the earliest manifestations that was described in vascular abnormalities in NF1 was renal vascular stenosis. And this is the renal artery with a big-time stenotic lesion in it. This patient presented with malignant hypertension. We get about one of these kids in town about every 3 to 4 years who shows up with malignant hypertension. And then eventually the NF diagnosis is made, and it leads to the renal artery stenosis diagnosis. We've had patients with renal artery stenosis who haven't had their NF diagnosed until 3 years later because nobody looked at their skin or eyes. So that's renal artery stenosis, but another very important vascular malformation in NF1 is cerebral vasculopathy. Here, this is the normal carotid artery on the right. This is the carotid artery in this patient with NF on the left. This is a patient who has carotid stenosis, and you can see there's markedly decreased circulation to the brain. One of the procedures that Dan Gilliam does here is pial synangiosis, where you transfer PIA over the area of ischemia, and it revascularizes and backfills all of that so that can be repaired. The syndrome, of course, that results from any kind of proximal stenosis is Moya-Moya syndrome. And for you guys keeping track of medical trivia for your boards, the 3 syndromes that I always say are associated with Moya-Moya are NF1, Down syndrome, and sickle cell disease. Sickle cell Moya-Moya is much less common these days since we've begun to prophylactically treat those patients. This is a patient who came from an outside institution, and at that outside institution they had done just a surveillance MRI in this little child looking for neurofibromas, and we brought in all the outside films because this kid had unexplained failure to thrive, and the neuroradiologist looked at the film and said, you know, the spine is fine, the spinal cord is fine, but what's with the coarctation of the aorta here? And he's actually got a fusiform coarctation. The whole aorta is small, but you can actually see the kink there, and our imaging here at the university really displayed this quite well. Here's the aortic arch coming around, and all of a sudden it cuts off. This coarct was repaired by Tony here, and actually another reason for his failure to thrive was found. He had a vascular ring up above that wasn't permitting him to swallow. That was fixed, but then we were left with this long fusiform attenuation of the aorta, and now he's got mid-aortic syndrome, which is another thing that can happen in people with NF, so it's problematic and once again requiring long-term follow-up. Congenital heart defects are actually more frequent in NF1. Some series up to 6.4% of patients have congenital heart defects. There's a very high frequency of pulmonic stenosis, just as we hear about in patients with Noonan syndrome. There's a low frequency of conotruncal defects, and coarctation is generally, as I showed you in our patient, the long fusiform type. Neurofibromatosis type 1 is an important learning disorder. I'm co-opting Rini-Pierpont's data here to show you what we've done here at the university. It's a kind of a general knowledge that ADHD or ADD is associated with NF1. Rini looked at our NF1, at a group of patients with NF1 who are school age. She also looked at a group of patients with another major retinopathy, Noonan syndrome, and then the unaffected sibling group, and we compared them in several different ways. One is looking at ADHD and the frequency of ADHD in NF1 relative to Noonan syndrome, more frequent, and then here are the unaffected siblings. 8 of 21, or 38% of the NF1 group had diagnosable ADHD. However, autism spectrum disorder is equally as common in this patient group, and so this should always be remembered. In our NF1 group, you can see that slightly less than half were typical, and actually the majority had mild to moderate or severe symptomatology of autism spectrum disorder. This is something that we see all the time in our clinic. And then in childhood and going beyond, depression is a very important part of our patients' lives. And you can see the parent rating early in life is statistically significant compared to the siblings, and even the child ratings in NF are higher. So in our adults, depression is essentially a constant, and it's independent of the burden of their disease. Social skills in kids with NF, you can imagine if there's some autism spectrum disorder, that would be an issue anyway, but certainly kids with ADD have social impairment. And we can see that if you look at a scale of social skills, the normal siblings, Noonan syndrome, NF, you can see that it's statistically significant that they have a lot of social skill issues. Social competence, children with NF1 are at risk for both social skills deficits and social problems. They're often ostracized. ADHD symptoms are associated with poor social functioning. And children with NF1 demonstrate more traits of ASD relative to unaffected children, for sure. Finally, and how I got involved with NF to begin with, neurofibromatosis is a cancer predisposition syndrome. If you look at NF cancer risk, 25.1% of patients with NF1 will have cancer by age 30. That's a 31-fold risk compared to the general population. Malignant peripheral nerve sheath tumor and glioma account for 63% of all NF1-associated cancers. The standard incidence ratio of breast cancer specifically is 11.1 when you're less than 40 years of age, an atypical age group for breast cancer. And the standard mortality ratio is 5.2 in that group. Other tumors with a high standard incidence ratio in NF include gastrointestinal stromal tumor, and this is NF1 GIST, not wild-type GIST, so it doesn't respond to the usual therapies. Malignant fibrous histiocytoma, rhabdomyosarcoma, and of course the textbook pheochromocytoma. There was a recent publication in the Journal of Clinical Oncology looking at the NF population in Finland, where they have really outstanding population statistics. And they looked at first cancer risk by age. And you can see this is NF women, and their cancer risk exceeds men up until about age 50. The incidence per 1,000 patient years, again, you can see that women, I'm sorry if the light's going out, women exceed men early, and then men take off later. The standard incidence ratio and then the standard mortality ratios are very high compared to the general population. This is a child we saw who had just had a surveillance MRI at another institution a few months earlier, who then presented to us with new symptoms and had a medullocervical pilocytic astrocytoma. This is a patient who came to me with a grade 2 fibrillary astrocytoma, and I think you can see he's got a small biopsy defect here, but I hope you can see there's asymmetry. This side is lighter and has mass effect compared to the other side, and he presented to us with neurologic deficit. So we treated him with what was considered standard therapy at the time, which was temozolomide and radiation, and within 1 year, he came back to us with a glioblastoma multiforme and quickly expired. This is a young lady who came to us for a bone marrow transplant. She had NF1 and a bone marrow disorder. She received low-dose TBI as part of her conditioning, and again, within 1 year of her transplant, her PET scan positive lesion in her right elbow was large, quickly growing, and painful, and this is a malignant peripheral nerve sheath tumor. And she's got metastatic disease and is in a very tough way right now. I just wanted to pound on this a little bit more. Patients with NF1 are not standard patients, and we are doing everything we can to avoid any hint of radiation in any of these kids and adults. And this should be considered when you're doing surveillance. Breast cancer, for instance, doing a standard mammogram probably isn't the best way to go. MRI is probably better and frankly more sensitive, and given the risk ratios that these women live with, I think it's an appropriate technology. We've seen now these 2 cases of people with second malignancies, and these are just 2 of many. And so we in the oncology field have to be very cognizant of that when we're doing therapy planning. The final diagnostic criterion is having a first-degree relative with NF1. Interestingly, NF1 presents half the time as a founder mutation in the family. So this isn't, a family history is not always reliable and shouldn't be considered as a primary diagnostic criterion. Examining unaffected parents is always important because guess what? A bunch of them do have NF1 and some of them have segmental NF1 that I'll show you in a minute. And finally, there is no reliable genotype-phenotype correlation. There are mutations all over the neurofibromin gene, and none of them really correlate well with anything specific as far as predicting a patient's course. This is a family who lives here in town in North Minneapolis, and one of the aunts made this genogram for me, which is really nice, and this shows a really clear autosomal dominant inheritance pattern in the family. X's represent those who have died, and there have been a couple X's since this was made. NF1 gene testing. It is preferred that testing always be coordinated through a neurofibromatosis or rasopathy clinic with involvement of a genetic counselor. This is really, really important so we get all this done right. Dermatology participation may be required in suspected cases of mosaic or segmental NF1. That is, they'll get a skin biopsy to match with our blood sample. And finally, it's preferred that all NF1 gene testing, I'm advertising for UAB, I should have put that in the disclosures, but I'm not getting anything back from them. NF1 gene testing should go through the University of Alabama in Birmingham Medical Genomics Laboratory. They actually keep a repository of genotype-phenotype correlations. Spread 1 was discovered because of this laboratory because they kept seeing an NF variation that didn't go with the neurofibromin gene. And there's a number of other discoveries that have been made because we all consolidate genotype and phenotype knowledge in this lab. And they've actually branched out now, so they're doing a Noonan rasopathy panel of 13 genes for non-NF1 cases. This is a patient with segmental NF. This happens to me every once in a while. I'll have the dads take off their shirts or ask the moms if I can examine them. This patient has normal skin everywhere else in his body, but he's got this patch in kind of a little, it goes over the back too, over the shoulder, and these are all cutaneous neurofibromas, and he ended up having segmental neurofibromatosis when we did this. And remember, in segmental neurofibromatosis, it's not just what you see. The whole point is it can involve the gametes too, and so these people can pass on NF1. So this is a summary of the NIH diagnostic criteria that we just went through, but there are other additional diagnostic criteria that I want to underline and that aren't often mentioned. Number 1, macrocephaly is universal in this population, and everybody with suspected NF diagnosis should have a head circumference measured. If it's normal, it's likely they don't have NF1. The other reason to do this, of course, is because people with NF1 can have brain tumors, and if you measure a head and it's big one day and it's way bigger the next, you've got to worry about the presence of a brain tumor and doing an MRI. UBOs I talked about previously. The neuropsychological disorder that I mentioned is essentially universal. Everybody's got something. And I've got 3 patients in college here in town right now who are doing brilliant work, but they know exactly where their deficits are, and most of them are involved with disability offices at their colleges. Pes planus and ankle valgus are essentially universal in our NF population. It's one of the common things we do in all the kids who come in between the ages of 3 and 10. I think all of them are in foot orthotics now. And I'm one of the few clinics that really pays attention to that. But if those of you who work with me see kids running down the hall, that's what I'm looking at. It's really quite remarkable. Velopalatine incompetence is very common in young children with NF, and it leads to a speech disorder they all have early on. It definitely gets better with speech therapy over time, but some kids have ongoing velopalatine incompetence and have swallowing issues and ongoing nasal voice issues. And then finally, hypertension. Hypertension not only because of the vascular disease I showed you, but many of these patients, and actually most of them, end up growing up with essential hypertension. And so a good blood pressure, anytime you see cafe au lait spots, a blood pressure is part of what you do for these people. I'm going back to our chemical pathways briefly. Remember RAF, MEK, ERK, PI3 kinase, mTOR. We actually combined mTOR inhibitors and MEK inhibitors in a study we did in Dr. Largaspada's lab here at the university, and we showed the combination really improved cell killing in a schwannoma MPNST cell line we had. And that discovery and discoveries in other labs led to the development of other drugs, MEK inhibitors. And just recently in the New England Journal, the Neurofibromatosis Consortium published their results of a clinical trial using one MEK inhibitor called selumetinib. This is a patient who had a very large plexiform neurofibroma of the buttock that you can see disappeared over time. They actually measured this response volumetrically. Patient number 7 in the article is actually my patient. And this is a young man who had this very debilitating plexiform neurofibroma of his right abdomen and lower extremity from very early in life. And he's participated in nearly every single phase 1 and phase 2 trial that the NIH has had. We've sent him out there for that and done monitoring locally for them. And you can see this is how his plexiform neurofibroma has grown over time despite all these efforts at intervention. And then he was put on selumetinib, the MEK inhibitor, and he had a remarkable decrease in tumor volume. However, he developed a cardiac issue. There is a decrease in ejection fraction in a number of patients who take MEK inhibitors. So he was taken off and his tumor immediately rebounded. He was put back on at a lower dose. His heart has been just fine ever since we've been monitoring him here. And once again, his tumor is beginning to regress. We've used this knowledge, too, to treat patients. I showed you before the crappy things that happen when you radiate brain tumors. This is a young lady with neurofibromatosis who came in with an anaplastic astrocytoma of the spinal cord. And rather than giving standard therapy with radiation and chemotherapy, we did a decompressive surgery, and she's being maintained on a MEK inhibitor, trametinib, in addition to an mTOR inhibitor, everolimus. And with those, she's now 2 years out with an anaplastic astrocytoma with no evidence of progression. Oops. We're now the home of one of the large projects focused on diseases within NF1, and I work with Dr. Largaspada, and we work with a company called Recombinetics, which is a university spin-off. And what Recombinetics does using TALENs or CRISPRs, they insert genes or take out deletions in pigs, and we've developed an NF pig that has cafe au lait macules, dermal neurofibromas, and we're using those pigs to check out new therapies for NF1. So early detection of NF1 is important. This is for all the pediatricians to know. You have to establish early screening for optic glioma in all of these patients, early screening for developmental differences and learning disorders, vasculopathy screening, including, of course, blood pressure measurements, and then early attention to plexiform neurofibroma development and management of skeletal dysplasia. All of these factors are part of a history and physical every time you suspect NF1. The take-home messages from today: NF1 is one of the most common genetic disorders. In the Twin Cities metro area, there are 1,000 people living with NF1. The diagnosis is only the beginning, but certainly not the end, of comprehensive NF care, and opportunities to help this patient group are truly endless. Care involves a lifelong relationship. And with that, a quote from the late Hubert Humphrey, and I'm happy to take questions. Thank you. John first, then the obligate Niglia question.
Thanks, Chris. That was fantastic. It's a talk that I wish I'd heard before I took my boards. I have so many questions, but if I may, I'm going to ask you two. One, you talked about the early detection of plexiform neurofibromas in children, maybe at the age of 3, and how important it was to actively follow those things up. Is the follow-up primarily to monitor the growth of a plexiform neurofibroma, which might be rapid at that age, or is it more active surveillance for plexiform neurofibromas in other locations? In other words, should we be looking for things near the spine or other vital structures in kids that have a detectable plexiform neurofibroma?
Yeah, you bring up an interesting point. With plexiform neurofibromas, usually what you see is what you get. Paraspinal neurofibromas are a whole different ball of wax that don't tend to emerge until early adulthood. But once a plexiform neurofibroma, it's highly unlikely you'll see one anywhere else, which is one of the oddities of the disease. There's very much a field effect with this condition where you see things all happen in one spot. And so why do we want to know? Well, number one, is it near vital structures? And we definitely see plexiform neurofibromas that cause airway obstruction, urogenital obstruction, other major organ obstructions, so we really watch for that carefully. And I've showed you that there are now actually medical therapeutic alternatives for these patients that can be employed early. And so getting these kids enrolled in a clinical trial early with a MEK inhibitor very frequently is very beneficial.
And then the second question I had, you talked about the high prevalence of neuropsychological disorders in these kids. Mm-hmm. You also talked about the almost uniform presence of UBOs on early MRIs and sort of waved those off, said, well, these go away. But might there not be some association between what you see on MRI and the development of these neuropsychological disorders?
There might be, and they've tried many, many times to correlate UBO number, presence, anatomic distribution, and nobody's been successful in sorting that out. I will tell you there's a mouse model of a neuropsychological disorder and they've seen that there's RAS upregulation in certain areas of the brain, and they've actually used RAS modulators to treat that in mice, and the mice have improved behaviorally and through maze learning, things like that. And so we think it's more a chemical lesion than a structural lesion that causes the disorders we see.
Thanks. I'll turn it over to Joe for the audience cheers.
Stop teasing. So an easy question and a longer question. What's the average age of diagnosis of NF?
Oh, that's a good question. I don't know, but my hope is we're driving it down because the clinical features are present very frequently at birth. It should be at birth. But I think looking at our whole clinic, I would guess probably around age 5 would be the median.
Then second question, on one of your earlier slides, you showed that the plexiform neurofibromas that are diagnosed at younger ages grow faster. They're more aggressive. So is that finding also associated with a greater risk of MPNSTs or malignant tumors?
That's a really good question. Everybody who has a plexiform neurofibroma is predisposed to MPNST because the great majority of MPNSTs arise within a plexiform neurofibroma. There's other things. We see that the patient I showed you with the subcutaneous neurofibromas, we're starting to see that those are the patients who seem to be at really high risk for malignant peripheral nerve sheath tumor. And remember, even though you've got a fast-growing plexiform neurofibroma in a 3-year-old, when is their MPNST going to show up? Not until ages 15 to 30. So there's something that switches or happens along the way, but nevertheless, those are the patients who you don't just kiss off and say, oh, they've got a plexiform neurofibroma, we've taken care of it. No, you haven't, because the MPNST will revisit you later.
Chris, that was a beautiful talk. Silly question, but I'm beyond embarrassment. I'll go ahead and ask. Why is the aberrant form of the protein dominant, right? If it's an autosomal dominant mutation, why doesn't the normal version compensate? Is there some sort of chimerism? And then the follow-up is, what about gene therapy?
Where's Mariella? Are you still in here? She's sitting in the back.
And then has gene therapy ever been tried?
Yeah, well, gene therapy is hard because there is not a hotspot mutation. And certainly that's something that people have thought about, but just because you can't replace a whole gene that is so necessary to pretty much all of our function and development, it's not one of those conditions that's really going to be amenable to it. We've already shown, however, in making these pigs, that we can give NF and we can take it away. And so when you're talking about gene therapy, I think you're talking about a brave new world where you're actually doing preconception therapy or just post-conception. Yeah, well, it would be way in utero. You're in a petri dish. Yeah. Do you want to talk about the why this is a dominant condition, Mariella? Can you help us? Well, hold on. There's a microphone coming.
Well, I honestly don't know exactly everything about the specific mutations within all of the different people with NF1, but in the RAS pathway, many of the different other disorders are all activating mutations rather than, loss of function mutations. So maybe that's involved in the causation of the dominance.
Okay. Makes sense. All right. Thank you very much. Have a good day.